Today we're talking about adolescent bone health. I've been interested in adolescent bone health for over 2 decades, and I'll show you some of the unique ways that we approach studying adolescent bone health here at Purdue. First, let me introduce you to the lifespan glance at how bone mass is accumulated and unfortunately tends to be lost later in life. So you have this interaction between environment, such as diet and exercise and maybe bad habits, with your genetic predisposition for building peak bone mass that interact with each other to determine how much peak bone mass you acquire during your growing years. So as you become an adult, you achieve your adult height, and then you have a little bit longer for bones to consolidate and build. And it depends on the bone site how long that takes. Your hip, for example, finishes earlier, and you don't grow any more peak bone mass after about age 16. Your spine takes the longest, so you can still grow a little bone mass during your college years, but not a lot. So most of the influence you can have on your ultimate peak bone mass occurs during puberty and those years that span adolescence. If you miss that, you've missed the window of opportunity to really grow peak bone mass. The higher you build your peak bone mass when you're young, the less risk you have of going into a fracture zone later in life. Let me tell you just how quickly bone is accreted during adolescence. And this is different in humans compared to some other animals, like a rat model, for example, has no really sharp peak. But notice how sharp the peak is for boys in blue and girls in pink. This is the rate of bone accretion per year, showing really you only have a few years to build about half of your adult skeleton. In the 2 years between ages 12 and 14 for girls or 13 to 15 in boys, you acquire a quarter of your adult bone mass. And if you go the entirety of puberty or adolescence, you acquire 40 to 50%. So that's a really critical period to do good or to do harm. Now, some people are genetically predisposed to have a really high bone mass, and you can mess up with your diet and your exercise choices and still have pretty high bone. And some people are the opposite. They're so genetically programmed to have poor bone mass as an adult that you can't do much with diet and exercise. But most people fall in the area where your lifestyle choices make all the difference on your risk of fracture later in life or the disease called osteoporosis. So about 40 to 60% of your bone mass is considered to be influenced by environment, like diet and exercise, and that's enough to help most people not be at risk for osteoporosis later. But unfortunately, our choices don't permit our bones to grow the maximum peak bone mass and eventually to prevent the loss later in life. So we're going to learn something about these choices and how important it is, especially during these adolescent growth years. What causes you to go into this accelerated bone accretion with puberty? It's your hormones that are genetically predisposed to increase or decrease at certain levels. So let's talk through this slide. You have the sex steroid hormones on top in blue that start rising in pre-puberty, rise considerably during puberty, and then sort of level off. And the main one is estrogen. Now, testosterone in men do have an influence, but not as much as estrogen in men as well as women, interestingly enough. When you start acquiring enough estrogen, you go into puberty, And then you get enough estrogen, your epiphyses of your long bones, or the ends, close, and you stop your linear growth. So on the beginning side of the estrogen climb, you have an influence on accelerating bone, and then when it gets high enough, it has an influence on stopping the growth, both. The pink line is peak bone mineral content velocity. So this is a more elongated look at the last slide that I showed you, where there's a sharp peak around adolescence and then a decline. What seems very related to this peak velocity of bone mineral content is insulin-like growth factor 1, a growth-like hormone peptide that's shown in green. When that starts growing or accelerating, that's when bone mineral content velocity starts accelerating. Even more than growth hormone in red is the influence of IGF. When we put into our models both growth hormone and IGF, once IGF is in there, growth hormone values don't add anything additional to the model. This slide shows you what I was just saying about fracture risk is associated with puberty especially, or early puberty. So you have boys in blue on the left and girls in red on the right. And what is interesting about this slide is there's been an increase in fracture risk over the last 3 decades. So these data are from Mayo Clinic, but this has been shown in several sites, both in the US and abroad, where there's been 62-63% increase in incidence of fracture during adolescence in boys and girls since 1970. And we know why there's the peak at adolescence, and I'm going to explain it more in detail in the next slide. And then we'll get on to why is there an increase rate over time? Why have we had an increase in childhood obesity? Well, first, why is there this high peak around early puberty in incidence of fracture? So we're going to look at males on top in this slide and females on the bottom. And what it shows you is the change in bone mineral density. Look at the blue square. There's a very big dip in bone mineral density right at the peak growth period. And that is because, remember that slide I showed you where peak height velocity preceded bone mineral content accretion? So for this period of 7 months to a year, adolescents shoot up in their height before their bones consolidate and the mineralization catches up, and they're in a period of low bone mineral density, much like a postmenopausal woman or an elderly man. And if you now look at the red square line, that really coincides with the fracture rate. In that period when they have the lowest bone mineral density, they have the highest fracture. So they are very vulnerable to this time. Now let's get to why have we had an increase in fracture? Probably because we've had an increase in obesity during adolescence and in childhood. And overweight children have an increased risk of fracture. Well, there's many theories about why there's obesity in childhood leads to increased fracture. Maybe they have greater force when they fall and they break their arm because you put your arm out to break that fall and your radius cracks. Maybe it's because they've grown less physically active. Our environment hasn't encouraged physical activity the way it used to, and we're so absorbed in our computers and our technology that we have a less physical activity. We have poorer balance because we're less physically active and we've developed less muscle mass. We have lower bone mass for weight, and we've stopped drinking as much milk. Milk consumption has declined. That's our major source of calcium. So this low calcium intake may interact with low bone mass for weight and cause increased risk for fracture during this critical period. If you had a 10% increase in peak bone mass by nutritional diet changes to optimize nutrition and or exercise, this could delay onset of osteoporosis by 13 years and decrease risk of fracture in postmenopausal women by half. That's huge, what we can do in adolescence. Well, the issue with diet mostly relies around dairy for getting enough calcium, but not just calcium. There's all these other nutrients that milk and dairy products provide important to bone health. It provides all the calcium you need, but also a big part of the potassium, magnesium, zinc, riboflavin, vitamin A, folate, and vitamin D. All those nutrients, all essential nutrients, are needed for bone because it's a living tissue. The MyPlate from the Dietary Guidelines recommendation and how it's translated into food guidance, for most groups, including adolescents, it's recommended to have 3 cups of low-fat milk or the equivalent a day. And that's to provide the calcium, but also the potassium and the magnesium and all the things needed for bone health. But here's where the average intakes are for Americans for the different age groups. And let's focus in on adolescents right now. So adolescent boys age 14 to 18 get 2.3 servings. They do the best at meeting the recommendations of any group. But adolescent girls, where we really have to worry about 50% of women over 50 will get osteoporosis. And here's the critical period where they could make a difference in building bone mass, and they're only getting half of the recommendations in age 14 to 18. Just a little bit younger, going into that rapid peak bone mass accretion period, boys get 2.4 of the recommended 3 servings, and girls age 9 to 13 get 1.9. So not much better than a little bit older. Woefully short, and we need to correct that. Children who avoid milk are at an increased risk for bone fracture. In New Zealand, it was first demonstrated. Now it's been demonstrated in other places. Milk avoiders had a risk of fracture of 34.8%, and their birth age matched cohort, geographically matched cohort, only had 13% risk of fracture. So big influence on whether you include dairy products in your diet or not. Diet is not the only important lifestyle choice. Exercise is also important. And children who engage in regular physical activity during the 2 years around peak height velocity gain 30% more bone than their non-active peers. Often we find exercise and nutrition work together. They're interactive. And it makes sense. You need the pressure on your skeleton, the weight loading, to tell your body, your bones need to have a high mass, and then you need the raw materials from diet to allow it to happen. So your body responds to the weight loading or exercise, and diet's important to allow it to build. Now, it's not just exercise, it's the type of exercise. You have to load your bones. So walking helps, and jumping rope and dodgeball, those kinds of games, soccer, are all fabulous for bone. What's not so good for bone is swimming. Now, swimming's really good for other health reasons, but you're unloading your skeleton in the water, which is taking on some of the weight for you. So that's not your best bone choice of exercise. So in conclusion, bone mass tracks from childhood to adulthood and predicts fracture. Adolescence is a critical window for building peak bone mass and size and strength that we used talked about in our prediction models. Diet and exercise can have a big impact on skeletal growth, especially during childhood. Milk avoidance is associated with increased risk of fracture. Thank you.